Morning, my name is Panagis Lykoudis. I'm a surgeon at the Royal Free Hospital, and what I'm going to present is a novel curriculum based on virtual reality laparoscopic simulation for sigmoidectomy, because there is room for surgeons in laparoscopic simulation, VR simulation. So the background, patient safety is the top priority of any healthcare service. The patient expectations are rising, and they should, and there is lots of pressure on the service. So this means shorter training times for the trainees. This means fewer training opportunities. There is a constant complaint, there is a constant concern that trainees, surgical trainees, don't get enough time to develop their skills regarding surgery. So there is a need for adjunct training. There is a need for them to find ways to develop their skills, to build up their confidence, to build up their curriculum, their CV as well. So there is always room for simulation training. So far it had been a little bit difficult in open surgery to create this kind of environment that realistically simulates open surgery and have the trainees trained in that situation. But now with laparoscopic surgery this is becoming easier, because laparoscopic surgery is already screen-based. So all we have to do is convert this screen-based situation, real-life situation, to a virtual reality environment. And we have virtual reality high-fidelity systems, high-fidelity laparoscopic simulations and simulators. We have the software that we need, we have the modules that we need to do that. What is missing is a curriculum. What we're missing is the metrics, the tool, to offer this educational opportunity, to assess how well it functions, and to develop further tools to assess the impact that it has in real-life surgery. So we are training them, they are achieving the goals of this virtual reality curriculum. How is this translated into real-life practice? So what we did is we used this high-fidelity laparoscopic simulator provided by Synbionics, the LAMP Mentor 2, the second generation of the simulator, and we used the sigmoid colectomy module that is already loaded on the machine. We invited 6 expert surgeons. Each of them had performed at least 100 procedures. We're talking about sigmoidectomy, left-sided colon resection. We used the Delphi method to assess the metrics, which means they all sat down in a table, and we had the first round of questions regarding what the metrics, what the thresholds for the trainees, for the students should be, and following subsequent procedures we decided exactly what the targets would be. The performance of the expert surgeons was also recorded, and it was also taken into consideration because we didn't want to ask too much from the trainees. And eventually we came with pass scores. We invited 14 trainees. We recorded some pre-performance data about exposure in previous virtual reality programs. We recorded their exposure in video games, and this might sound a little bit funny, but it is important, and their experience with musical instruments, because it has to do with dexterity. And they had an induction where we showed them how to safely use the equipment, some short lectures about the theory behind this kind of operation, and then self-directed practice, which is very important according to our opinion. It was low dose and high frequency, which means that they had the opportunity to use the simulator many times, but not for a too long period, because we know that this is negatively affecting the learning. They had a total of 60 days. They went on for 23 attempts, and at the end of that they had a formative assessment, which means we didn't just focus on the metrics recorded by the machine, what we have, the numbers in front of us, but we also assessed them for things that cannot be recorded. So we put our experience as surgical trainers along with the numbers generated by the simulator. And eventually we did a learning curve analysis, and this is one of the original parts of this study. This is a picture of what a specific part of the operation looks like. For those that are aware of the operation, this is the dissection of the inferior mesenteric artery, a key point during the operation. And if we have a minute at the end of the presentation, we will also get a glimpse on the YouTube video that we have uploaded with a full procedure. So we recorded the outcomes of the experts. And as I said before, based on this and based on the Delphi approach, we came up with the thresholds that the trainees should achieve so that they can get the competence. many different parameters. I would divide them in two big groups. The first group would be safety parameters, like energy device safety, accuracy of mobilization, risk of injury to the bowel, and economy parameters. How quickly they could perform that, time to complete the whole procedure, number of movements for each hand, and the total path length of movements for each hand again. And then we did an analysis of construct validity. We wanted to make sure that when they start and when they finish, there is an improvement, and there is an improvement compared to the metrics of the experts. And indeed, those parameters that we expected that would demonstrate some construct validity are obviously the scale parameters, total time, and the number and path length of movements. And then we created the learning curves. This learning curve is depicting the progress regarding the time required to complete the procedure. You can see a very steady decrease in the time that they actually needed in order to complete the procedure, and this one is showing the number of movements and the total path length. What is important is for all practically 5 learning curves, there is always a point around the 13th and the 14th attempt at which they are achieving competence, which means that the attempts are below the line that was set as a threshold according to the experts' metrics. So we do have an endpoint in this curriculum. We do know that after the 13th or 14th roughly attempt, they are consistently achieving the scores that we had set for them. And I mentioned earlier that we had collected some pre-assessment data because these are important possible confounding factors as far as the learning is concerned. And we found actually that younger trainees would achieve their goals earlier than older trainees. Female trainees, as expected, were much better. Previous simulation experience also had a favorable effect on the learning curve. And finally, experience with musical instruments also had a positive impact on their learning. The importance of these findings is that when we design curricula for virtual reality training, we need to take that into consideration. Not everybody learns at the same pace. And for some of them, it might be necessary to complete 23, 24, 25 attempts, but for some of them, they might be able to achieve these metrics within 10 or 15 attempts. So this gives us the opportunity to tailor training, to tailor learning. The whole idea was eventually submitted and published in the American Journal of Surgery, and I can confidently say that this is the first published and implemented virtual reality curriculum for laparoscopic sigmoid colectomy. The conclusions are that we managed to create a valid curriculum with construct validity, I mean. We based that on metrics, on numbers, objective numbers that also work as a motivation for the students. They can see their improvement and they know what to aim for. And it's not just numbers though, it also measures, apart from efficiency, it measures safety, which is very important and had been overlooked in the last few curricula that have been published on other types of surgery. We included a formative assessment, as we would do for our trainees in theatre. We found that 14 attempts are needed on average for them to achieve the goals that we have set. We identified favorable factors which at some point can be used to tailor training. Obviously, we're going to run further studies for assessing the benefit for patients. We first needed the results from this study so that we can use it as an argument for assessing that on a larger scale, including patients. And as I mentioned a couple of times, we're going to perform a sub-analysis of the individual learning pattern, individual learning curves for obviously a larger number of participants. That should be all.